Hello, my name is Mehilli from Munich, Germany. I'm here at the PCR TV studio and I have the pleasure to talk with Professor Gert Richardt from Bad Segeberg, Professor Joe Dentz from Henk, Belgium. And we will speak about complex coronary interventions and the role of imaging of improving these interventions. So let's start with you, Gert. My first question is, we are doing a lot of complex interventions and we have a lot of complex patients. How can imaging help us to plan the strategy of interventions in these complex patients?
If you look at the left main interventions, for instance, if you see that there's calcium or if you are not very clear about the anatomy, I would recommend you to start with an OCT. This gives you a clear picture of the dimensions of the different branches, and it can give you more detailed information about the load and the distribution and the depth and the whole burden of the calcium. And this will give you an idea which preparation of the lesion is necessary and how many stents you will finally need to treat them properly.
Can we with OCT see the appropriateness of stent deployment, or can we use other imaging techniques to see how good is the stent deployed?
Yes, we can obviously use the OCT, but that means we have several runs of OCT. We now have the new technique of this stent enhancement, clear stent angio modality. And this is something that I personally like very much because it's a straightforward strategy. You can see the stent nicely, you can see how the stent is expanded and how the stent placement has to be done best. So I think this is a clear achievement and a good addition to what we see with the intravascular imaging techniques.
So we can also better place the stent in the multiple stenting technique, avoiding overlapping and things like this with clear stents.
But use several angulations to be sure that it is
You're
perfect.
Right, yes. You're right. But what about the CTOs and the computer tomography? Can computer tomography help us when we do these kind of complex interventions?
I think for sure. Because CTOs are very complex lesions, and first of all, the diagnostic angiogram does not learn you all the aspects of the CTO. For example, the entrance point, if it's calcified, yes or no, it's often unclear. The really exact lesion length of the CTO is unknown. And for example, if there are bends or strange curves within the CTO body, this is not shown by the diagnostic angiogram, especially in long and complex CTO lesions. So I think, yes, there is a place for CT scan up front, especially when you are in the first stage, I think, and if you master less techniques, I think then CT scan can really tell you how complex the lesion is, which strategy might be the best one or the first one to be used, and it even might help you also to decide to refer a patient to a maybe more experienced interventional cardiologist in CTO. Yes, for sure.
Except the single CT software that we use in the CTOs, do you think CT can help us also to avoid a little bit diagnostic angiograms? Not for the
yes, to avoid diagnostic angiograms, then it's about patient stratification and looking what might be the possibility that the patient has coronary artery disease. So I think in low-risk patients, there clearly should be a trend to use CT scan up front and not to impose the risk of an interventional procedure to this patient. So I think in low-risk patients we can select patients or have those patients who have no coronary artery disease, they will not have a coronary angiogram. Of course, the more complex and intermediate and high-risk patients, often we still need a diagnostic angiogram, a bit based on, depending on the test you do up front.
What about cardio MRI?
Yes, so cardiac MRI is of course one of the tests you can do up front. So in our center, cardiac MRI is used mostly in heart failure patients, so to look at the reason why they have heart failure, and one of them is of course ischemic heart disease. In CTOs I like to use the MRI to look if there's scar, yes or no, how big is the scar burden. It's probably underused in this indication. But of course there are also patients who have clearly symptoms and who have a normal LV function, and there I think it doesn't make sense to do technically advanced procedures to, because you know it's viable, it works. So, and there is a reason for treatment.
And what do you think, why is so underused, the MRI today?
Well, because not all the patients, well, some of the patients we have symptoms and have a normal LV function. So if the symptom is clear angina, and the LV function is normal, I think there's no reason to do so. That's one of the reasons. Then you have the patients who have quite atypical or no chest pain complaints, but have documented ischemia for some reasons. But again, if the LV function is normal, you will show on the MRI that there is viability. So there's only a small, it's not a smaller, but there is only a part of the population we want to treat that needs the MRI. But there it's still somewhat underused. One of the reasons, it's a bit country specific, I think. One of the reasons can be that there's not so much time for MRI, or the MRI is too expensive. And on the other hand, probably one of the best things to do would be an MRI perfusion, but that even takes more time and needs to be dedicated radiologists or cardiologists to look at, yes.
So Gert, if you want to summarize about the imaging and planning the procedure of complex interventions and multiple stenting, what would you say?
I would say there's still a place for intravascular imaging, but we have a new tool, which is the clear stent technique, that is a complementary and an additional imaging technique that helps stent placement, and you can ultimately judge the stent expansion and the continuity of the stented area. But after all, we are lacking data in this field, and this is a general problem with all the imaging studies, that we have not so much data that this is outcome relevant, but I truly believe that it is.
From the other hand, we have some meta-analysis, for example, in IVUS patients, in more than 25,000 patients, not only CTO patients, of course, but overall, when IVUS was used, PCI guided with IVUS and PCI without guide, there the meta-analysis show clearly that there's a reduction not only in TLR, but even in death and acute MI and stent thrombosis, and this was really, I think, a quite big series. Yeah?
But
So
this has to be extended to the new technologies.
Yes.
For sure.
Yes. Yeah.
So the future will be very excited, because we realize that imaging techniques will help us to make our intervention much better and much safer for our patient. Thank you very much.
Thank you.